So, what's the update with radiation therapy, specifically stereotactic radiation therapy as it relates to prostate cancer? Today's conversation is with Dr. Jonathan Haas. He's the director of radiation oncology at NYU Grossman School of Medicine in Long Island. And he's one of the best at this type of radiation where you focally treat the prostate and try not to hit other tissues around the prostate, or other benign non-cancerous tissues. He's one of the best at this approach. He's been doing it for a long time. He's one of the first ones to actually implement the form of SBRT, or the type of equipment called CyberKnife. And there are updates. They're trying to perfect the approach. There's a lot of research looking into, who needs androgen deprivation therapy while undergoing a SBRT? Maybe it's not for everyone. And what methodologies, what methods do we have to look into? Maybe this particular type of prostate cancer at a perhaps Gleason 7, 4+3 does not need androgen deprivation therapy while undergoing radiation therapy. Maybe the other group, Gleason 9, Gleason whatever, maybe they do need it. And what's the limit here? Who is not a candidate for SBRT or the type of equipment that Dr. Haas uses called CyberKnife? Enjoy this amazing conversation where this is a fabulous update on what's new, what's in the pipeline as it relates to SBRT, radiation therapy, and prostate cancer. Let's go. Before I proceed, I just want to clarify that this podcast and all Dr. Gio content is separate from my faculty position at NYU Langone Health. The views and opinions on this podcast are my own. Our guests and sponsors are curated by me and not affiliated with NYU Langone Health. Sponsors are a way for us to provide high quality information at no cost to you so that you can take better charge of your prostate health, testosterone, and erectile function, and also how to live better with age. Welcome to the Dr. Gio podcast. I am your host, Dr. Gio, where it is my intention and my purpose to help you optimize your prostate health, testosterone, erections, overall quality of life as you age, and live better with age. My guest today, you know everything about him from the intro, Dr. Jonathan Haas. John, thank you for being on, brother. Nice and early, Saturday morning.
Yeah, what a nice way to spend the weekend. I couldn't script this out better. Catch up, hang out with a buddy of mine, talk stuff that we like to talk about. It's thank you for having me.
Over coffee, since we can't do it in person. We'll do it virtual. Cheers, cheers, brother.
Next we have to do a happy hour. We'll do it that way.
That's right. Not a bad idea, actually. Except it's more like Joe Rogan's show. And I love Joe Rogan, but I don't want to be so Joe Rogan show. In any event, I thought to have you back because many of my listeners have said, look, this radiation thing, I'm still confused. Of course, many have watched your first episode with us on SBRT, which was great. I think today the conversation, John, is more about kind of an overview because I think the confusion is, so back in the day, right, I don't know, 20, 30 years ago, not a lot of options. Prostate cancer, surgery, radiation, period, end of story. Good news today, a lot of options. Bad news today, a lot of options.
That's right.
Right? How do we choose? And we are at a phase now which is fantastic, where we are promoting, encouraging shared decision-making, right? So now the patient can be a proactive participant in their own health, their own body. Great. But darn, we want them to be part of that conversation in a well-informed manner, not misinformed. So give us a brief overview of all the technology that's available. How does it work? Pros and cons. And again, not a masterclass, just an overview on what's available, type of technology that's used, and pros and cons with each modality.
Yeah, that's a great question. I could probably spend 90 hours answering that.
That's right.
We'll take the 20,000 foot view, right? So to your point, 30 years ago, it was chocolate and vanilla, right? Two flavors, surgery, radiation. And radiation was historically 9 weeks. Surgery was a big open procedure. And those were your two choices. I'm not going to delve into the surgical world, although I know about it. You've had fantastic surgeons on your show.
Mm-hmm.
So my job is a radiation oncologist, which is exactly what it sounds like, giving radiation for cancer patients. And radiation has evolved over the past decades to big 9-week, big radiation fields or radioactive seeds. But with the advent of technology, like everything else, radiation has become much more precise and much more accurate, much more convenient. So probably in the early 2000s, SBRT became available. Stands for
So that's stereotactic.
stereotactic body radiation therapy. Some people call
Also known as the brand name, which is such good branding. I have to say CyberKnife. Most people will still say CyberKnife,
so
but it is SBRT.
That's my area. That's my specialty, subspecialty, which is we've talked about in the past. We can talk about it more in the future, also on the show. But in any event, it's, SBRT, or also called SABR, stereotactic ablative body radiation therapy. Two terms for the same thing, are a way for us to give really higher doses of radiation to the cancer, in this case, the prostate, because this is a men's health show, but also for other tumors, brain, lung, pancreas, breast, and limit radiation to the normal surrounding anatomy. There's multiple platforms that can now do this. Our favorite here is the CyberKnife, which is a robotic radiation system that comes in at hundreds of different angles. You can have machines that have had adaptations with MRIs on it, where you can take an MRI during treatment. You have machines that have a cone beam CT, where you can do a CT before, all of which, for the most part, accomplish similar things. And as we talked about earlier, pretty much similar outcomes, right? Anyone that says this is the best, I would kind of look askance, right? And I'm going to use the analogy that you could give the same scalpel to two different surgeons and very different things are going to happen. You can give the same platform, be it X, Y, Z, and different things are going to happen for good or for bad. So it's without ego, you're selling the clinician, and a little bit short was saying, I want only CyberKnife. I want only MR-Linac. I want only TrueBeam. I only want Edge. I only want, whatever. It's way more than that. But the technology matters. You want to make sure that you have some form of image guidance, that you're able to track the movement of whatever the target is. In this case, it's prostate. You want to make sure that you're able to compensate for that movement, right? If I were to put me or you in a block of concrete before we kind of suffocated, our prostate would be moving, right? If I was in a block of ice, a block of concrete, my prostate would still move from breathing, from gas, from urine, from blood. So
hold that thought. Very important point. I don't think people know that. As it reminds me of a few clinicians, radiologists as well, that are doing MRI guided biopsies, right? Everybody's like, oh my God, that's great. MRI guided, great. Prostate is moving. Prostate is moving as you're trying to hit the target. Talk a little bit about that. So somebody is laying down and literally, so the prostate is continuously moving in what direction, how far,
right, so
and how does it make it difficult
right.
for the radiation to do what it's supposed to do?
I'm going to grab a model right here.
Okay, sure.
So this is a prostate.
Yeah.
The prostate right here. This is the urethra. This is the bladder. The rectum sits right behind it. So the prostate moves like an airplane, right? An airplane can move, X, Y, Z, also pitch, roll, and yaw. So many systems can only compensate for those three motions, X, Y, Z. We have a system that can compensate for all six, but regardless, whatever you do, you want to make sure that you're tracking all the movements in all points of time. Again, I'm not a urologist, but a fusion biopsy is able to kind of map the MRI with the ultrasound, and you generate a target. And I think it could compensate for the movement. You're probably better off asking one of the fantastic urologists you have on. But the bottom line is the way that they used to do biopsies used to be like a right and a left. Or maybe they did, 3 and 3, 3 on the right, 3 on the left. Maybe they started to do, 6, 16. So now what they do is when you have an MRI, you get what's called a PIRAD score. And that's where it goes from like 1 to 5. 5 is the most suspicious. 1 is pretty much not suspicious at all. And they're able to, in addition to doing, and different urologists will have different ways that they like to do it, but in general, what they'll try to do in addition to their standard biopsies is they'll target the higher PIRAD score, because that's probably where, almost certainly where the cancer is. and oftentimes where a more aggressive cancer is. You don't want to miss it. You don't want to have sampling error. So, we can't treat what we don't know what we're treating. So, I'm sure you've had millions of discussions from people smarter than I am about Gleason score and things like that. And you want to make sure you get the cancer. You want to target the most clinically significant cancer because that's going to guide treatment. But technology systems that we have in radiation are able to target the movement of the prostate, some in 3 dimensions, some in 6 dimensions. But the bottom line, you want to make sure that you're compensating for that movement, because back in the past, when you had big margins around your radiation field, it wasn't quite as important. If you couldn't see it, you knew it was going to be in that general area. But if we're narrowing the margin to 3 millimeters, which we are, and sometimes 2 millimeters, you want to make sure if it moves 4 millimeters, you've missed. And if the cancer's on the other side of that miss, you haven't hit the cancer. So that's a problem.
And you're potentially hitting benign tissue.
Right. You're hitting benign tissue, or you're missing the cancer. You're doing a lot of things that you're not supposed to do. I always joke that my job is super simple, right? It's marksmanship. I'm like I'm wearing this right here. I'm the Green Arrow, right? I'm a DC comic character in my green scrubs. But, if I could give 1 trillion units of radiation to the cancer and 0 units of radiation normal surrounding anatomy, I'd be able to cure everyone in that cancer. Problem is you can't. So you have to kind of be judicious in giving a highest dose to the cancer that you can and limiting radiation to the normal surrounding anatomy, the bladder, the rectum, the urethra. So all of the evolving technology is moving along that extreme to improve our marksmanships, our doses. Now we're looking to kind of maybe back off doses where the cancer is not. We alluded to focal therapy, where you're treating just that spot. Some people are now looking to potentially look on protocol to do focal radiation, or to do what's called an SIB. And we do that. We'll look to give a certain dose of radiation to the cancer, and an SIB stands for simultaneous integrated boost, where you're boosting the higher volume or higher cancer, so you're able to differentiate the dose. I tell everyone has a thumb, right? Everyone's thumbprint is different. Similarly, many people have prostate cancer. Pretty much everyone's prostate cancer is different. Where is it located in the prostate? What is the size of the prostate? What is the relationship of the bladder to the prostate, the rectum to the prostate? Where's the penile bulb? Where is the blood vessel? So we're trying to integrate all that into our planning while making sure that we give an ablative dose to the cancer.
Thank you for that amazing overview as it relates to SBRT. A few questions on that, and we can kind of hang out here for a minute, since I know this is a great passion of yours. 2 things, and after I hear you, 2 things seem to be important. Number one is, how is the imaging technology that you're using to find the cancer, right? And we're going to talk about AI in a few minutes. So how good is the imaging? It seems like it just gets better and better and better and better as we move along. And number 2 is this notion of the prostate moving and how good the technology is getting so that it can target what it's supposed to target, even though the prostate is moving. How good is that? I mean, maybe you said earlier, because I think you're very responsible. Look, one of the concerns with my patients is always, or with people, is, if you have a hammer, everything looks like a nail, right? So if I'm a radiologist, the opposite of what I've seen. When I send patients to you, I tell doctor, he will, if you're not a candidate, believe me, he's not going to just recommend this. So how good is that? Is the technology? I know that you use primarily CyberKnife. You mentioned a few other companies.
Right.
In an objective manner, do they all kind of focusing on this, on both things, the imaging and the movement component?
Yeah.
Who's leading the way here?
It's a great question. I think, again, everyone's good. I'm not going to say that we're better, they're better. Our accuracy on our system, which is a CyberKnife, is 0.7 millimeters. That's less than a diameter piece of hair. And if you're out of that range, the machine's going to correct for that. So, and the nice thing about it is our whole dose is going to move with that, right? We've designed a plan, and if the prostate's off, the dose cloud is going to move with the patient. So most of the systems that are out there have good imaging. Most of the systems have good targeting. What we do in our system here is we don't use the initial diagnostic scans. We don't use the MRI that was done before they came to us. We don't use the CAT scan at all. We use it for the consult.
Yeah.
When I do the consultation, I'll say this guy has a Gleason 7 in the right base and he's got a Gleason 9 in the left apex. But when we do our own radiation planning, we get our own planning scans. Everyone gets a planning CT. Everyone gets a planning MRI. We fuse all those together. Right before we do our treatment, we have what's called chart rounds, which is a QA. It's almost like a fly, don't fly. And we get a checklist. We use a system called ClearCheck, where all of the dose volume constraints, meaning what we want to treat and what we don't want to treat, it turns up green or red. Right? It's like a pilot before he gets on his plane. We don't fly the plane until, and sometimes there may be reds that are unavoidable. And some you just may have an anatomy that is just, you can't meet your constraints, and you do the best you can. You'll tell the patient, but you kind of, so it's individualized to that patient, and we're using our own updated imaging for our planning. And in addition, we're getting real-time imaging by tracking the fiducial markers that we've talked about in the past, that's going to be able to compensate in all 6 degrees of motion. This is one of the few systems that can do that. Many of the systems are on something called a gantry. It means it moves in a circle like a record player. And again, that'll work. Our system doesn't do that. The CyberKnife comes in at hundreds of different angles, and we're able to kind of compensate in all 6 degrees of movement. Does it make a huge difference? Honestly, I'm not sure, because I'm comfortable with it. That doesn't mean other people aren't doing fantastic radiation with their MR gantry-based system, with their CT gantry-based system, with their proton system. But we're comfortable with our hands, having used this system for over 15 years, that we know what we're doing. So the imaging is better, the precision is better. We're now even looking, we've talked about, we think we're precise enough now that we can go from 5 fractions down to 2 fractions. And we've started doing that. So we have patients on a study. It used to be back in the day when you and I talked earlier on the show about chocolate and vanilla, right? Only radiation for 9 weeks, only big surgery. Now what we're able to do, I love my patients, and I'd like to think the majority of patients are fond of me, but they don't want to spend time with me. They'd rather be with their family, right? So if I can get them back to their family in 2 days with equipoise, with equivalent outcome to 5 days or surgery, that's just better medicine.
Sure.
Right? So that's what we're trying to do.
You mentioned a few things that as confusing to our colleagues, but probably confusing to our patients. 5 fractions versus 2 fractions.
Yeah.
What does that mean?
So a fraction is the individual treatment session, right? So what that means, 45 fractions equals 45 days of radiation.
Okay.
5 fractions equals 5 days of radiation. Okay. 2 fractions is 2 days of radiation. So we've opened up a study this summer with colleagues here, some of my partners, and we've treated now probably 10 or 15 patients. It's on an IRB study, so that's super important. IRB stands for Institutional Review Board. Yep. As you know, we're Perlmutter Cancer Center, which is an NCI-designated cancer center. So we have what's called protocols. Protocols are the way that we advance medicine. And for a protocol to be activated, it has to go before something called an IRB. It stands for Institutional Review Board. It's kind of the most senior doctors in the hospital. You have to ask a question that you think is going to be safe, that you think is going to benefit the patient, that you think is going to make medicine in general better, and you have to jump through appropriately.
And not harm the patient.
You have to jump through 1,000 hoops, which is worth doing. Right? And you've done tough protocols, I've done protocols, but that's how medicine advances. Otherwise, we'd be treating patients with leeches, and so
or treating or over treatment, or exactly. It's not a great history before the IRB.
Right. So we opened up this IRB 2 fraction study, and it's so far, short-term follow-up. I've seen patients now out to 6 months, and they're doing great. And
so literally, so that I understand, literally, you're saying SBRT for 2 days, go home.
Pretty much, and we have follow-up with us, but yes, and we've done that.
That is. First of all, I thought 5 days was great. I'm like, oh wow, 5 days, right? So typically, when they're coming to me to help them navigate, hey, what do? I'm confused. Well, you talk to, an SBRT expert, look, it's only 5 days. Now we're talking 2?
Yep.
Wow. So within that time, whether 5 days or 2 days, are you always hitting that one tumor, the tumor that keeps popping up as we're treating
suspicious? The prostate. So most radiation treatment now treats the entire prostate. That's still pretty much considered standard of care.
Okay.
We may dose differentially within the prostate, right? Getting back to that SIV. But, I use the example when you have a prostatectomy, open, radical, robotic, all prostatectomies treat the whole prostate. Pretty much all radiation treatment at this point treats the whole prostate. The advantage of SBRT is that at the edge of the prostate, where your normal anatomy is, the dose falls off so quickly. That's why it's a better radiation treatment. But we're able to kind of differentially dose within the prostate the different doses of radiation.
And what you're saying is that we can get, or possibly get, because it's still under investigation, the same outcome.
Right. That's exactly what we're hoping
treatments
to do.
Versus 5.
100%. And that's our goal. We're trying to take a treatment that we know very well, SBRT in 5 fraction, which is convenient, right? 5 is better than 45. 5 is better than 28. Say, hey, can we do this safely in 2 fractions? And and we just make up the doses, right? There's preliminary data from something called high dose rate brachytherapy. There's been other studies using different types of radiation, I think a little bit more invasive, that this works. So we're trying to do a dose fractionation scheme, the doses per day that have been well established, and just do it in a less invasive manner.
Love it. But we don't know yet, and most people are not doing that because this is still under investigation. Is that right?
Pretty much, yes.
All right. So here in 2024, should the patient, when they go to see radiation oncologist, ask the question?
Thank you for watching the Dr. Geo Prostate Podcast. Take a proactive step and improve your health and vitality with the Prolon Fasting Mimicking Diet FMD, a 5-day plant-based program developed by Dr. Walter Longo, designed to mimic the effects of fasting without the challenges. Prolon helps activate autophagy, reduce inflammation, support weight management, and promote overall longevity, all while nourishing your body. As a special thank you, you can access the Prolon kit for just $148. Use the link below to get started. Empower your journey to better health today.
Hey, what machine do you have back? You have CyberKnife, or do you have the other? I don't even, honestly, I don't even know the names of the other companies. That's just, but should that be part of the conversation? Because in other words, they can ask, right? They're going to listen to this podcast and say, well, the movement of the prostate, I didn't know about the movement. Hey, the imaging. Hey, how good is the technology, your technology versus the other technology, looking at these two things?
They should ask. I mean, again, they should ask what technology you're using and how does it work. And again, I'm biased for CyberKnife, but I don't think you should just go in with one brand name. I think you should ask, what is your system? How does it work? What is the accuracy? How many have you done? Right. And what I like to do also is I have what I call a patient mentoring program. And I think you may have chatted about this in the past, where I have 30 or 40 men, probably like 50, 60 patients that want to pay it forward. They know what it's like to sit in that seat. You hear the word cancer, and not all cancers are the same, right? Cancer with a small c and cancer with a big C, even within prostate cancer. But, so I always tell my patients, take a breath. This is one of the few cancers where you have the luxury of time. You should seek multiple opinions. Don't let anyone force you into anything. Make sure you go to a place which has a multidisciplinary approach, meaning that you're not just seeing the radiation oncologist, you're seeing the surgeon. You have access to the cryosurgeon, the robotic surgeon, the radiation oncologist. If you want to speak to a medical oncologist, that's why I think in general, all things being equal, it's better to go to an NCI designated cancer center because they've already been pre-screened to have that. So ask about the technology, ask how you track, ask, can I speak to your patients? Ask what protocols are available, what's new and out there that might make my outcome better. And discuss it with your family, discuss it with friends, discuss it with other patients. I don't like when I see patients in second opinion and when they saw their first opinion, they've already been booked for something. I don't like that.
I'm pretty, so my work, it very well. For the few that don't know exactly about my work as it relates to as a clinician is 2 things. Number one is, what's reasonable in a natural lifestyle method that I can do to create a microenvironment that's hostile to cancer cells in my body, right? Number one. Number 2, they oftentimes see me for, hey, I am super confused. You don't have extra grind here. Help me out. And oftentimes they say something like I just said, well, everything, always, if you have a hammer, everything looks like a nail. Okay. I tell the patient, you're also driving that. In other words, you're looking anxious. You are anxious. You're the one that's booking also, by the way. And then say, wait, time out, not yet. Let me go. So I think, right, the people listening is like, okay, gather down, try your best to calm down. Look, I'm perfectly fine with prostate cancer being an emotional situation because it is. Hey, Dr. Haas, what would you do if you were in my case? I never answer that question. That's the worst question you could answer because I'm not there. It's not me.
Right.
I can say whatever I want now, but if I'm the one diagnosed, it's like, whoa, wait, time out, right?
Sometimes it can be self-serving, right?
Yes, exactly. What would I do? Yeah, I would only do holistic protocols for your Gleason 9.
Right. That's your wheelhouse.
Exactly. Yeah, right? So I think the patient also can learn how to be the best patient, just like we can learn how to be the best doctor in their particular situation. Always bring somebody else because they can listen to the things. Like you're saying a lot of things, right? They could listen and take notes, better notes even, on exactly what the practitioner said and so forth. All right, I'll get off
my patients tape me too, by the way. Because you give them, you're giving them 20 pounds of stuff in like a 10-pound bag, right? So it's a lot of information coming at them, and unfortunately, I'm like your typical New Yorker. I speak like a New Yorker. I sometimes have to dial it back to like we had a discussion before we got on the air, my Midwest training, like my St. Louis WashU training.
Yeah.
You gotta lay it out, give them the options, let them breathe. Yeah, there's a lot coming at these guys.
Yeah, there is for sure, and I think you do the same. We put ourselves in their shoes, John. Let's stick to SBRT because I'm loving this conversation. Things are evolving in ways that I didn't even know. And I'm like, well, we can just hang out here for a minute. Where are we? 2 years ago was the last time that you've been on this podcast. And as it relates to higher Gleason scores, you said we can do it, but maybe, SBRT for higher Gleason scores. The way I saw it then, the way I see it now, call me naive, cancer's cancer. If you have a tumor there that's a Gleason 9 versus a Gleason 6, it's a tumor in that location around the same size. Hit it with something. Hit it with SBRT. And if I'm a patient, or some patients, they depending on their personality type, they'll say, yeah, rather than take out my prostate, just hit it with this great, 2 treatments, hit me with some SBRT. Where are we now with higher Gleason scores and SBRT?
Yeah, I mean, higher Gleason scores, really anything above a Gleason 7 is considered higher Gleason score, higher risk. You're still at a pretty significant risk of having occult microscopic disease in the lymph nodes. So pretty much,
even if nothing is picking it up, not even PSMA.
Yeah, there's a formula called the Roche formula, named after a super charismatic radiation oncologist who's now become a friend of mine, Mac Roach from UCSF.
Mac Roach, he's known.
You should
tough cookie.
Have him on your show. He's wonderful. He's been in our course. He gave me a saying that I use now. We had our course in Arizona, and what he tells patients men don't want hormones, right? When we have a protocol I'd love to discuss, but men don't love hormones, right? Because it puts you into male menopause. But he tells his patients, listen, would you rather be on short course hormones now or lifelong hormones because you missed the boat and the cancer came back? And that kind of crystallized it for me as a 20-year veteran radiation oncologist. I'm like, that's like the perfect saying. I'm like, I love you.
That's right.
And so I say that to my patients and I give them that. But
because it also lets them know that I get it. I'm not just 100%. Trying to bombard you with things. I don't want hormones.
Right. But I want you to be here to be off the hormones. I'd rather be on the hormone. If you have high risk, I'd rather be on the hormones for 18 months to 2 years. And then you have the next 10 to 30 years of your life off of hormones, as opposed to say, all right, I'm not doing the hormones now. And then it comes back in 2 years. And the next 15 years of your life are on hormones. That's right. The deal, right? If you kind of cut corners. But
higher risk of hormone insensitive cancers and things like that, which is a huge concern for me.
100%. So Mac Roach devised a formula decades ago, and he integrated the Gleason score, the PSA. To oversimplify it, it's Gleason score -7 plus 2/3 the PSA times 10%. That's the formula. So let's say you have a Gleason 9, right? The high risk. Right off the bat, Gleason 9 -7 is 20% right out of the gate if they did surgery, even if you don't pick it up in imaging, that you'll have lymph nodes. And let's say your PSA is 10. So 2/3 of that is like 6.7. So you have a 27% chance with the Roche formula, even if everything is not picked up on imaging, that if they were to do surgery, that they would see microscopic disease in the lymph nodes. So flipping that back to your question with radiation, that's why we don't usually do SBRT alone for the high-risk prostate cancer patients, because we want to treat the lymph nodes also. You can do it in certain cases. NCCN, which is kind of the governing guidelines of radiation, said that hormones plus SBRT can be cautiously used in patients where it would be a medical or social hardship, right? So I never name names, but I had a very prominent surgeon in my office last year, full schedule, booked up, and said, listen, I can't come back for weeks and weeks of radiation. So we imaged him, PET scan, PSMA PET scan, MRI, everything was pristine. We put him on hormones, and he had SBRT alone. And again, with short follow-up, he's a couple of years out, he's doing great. But
hormones with SBRT.
With SBRT. So I don't think you should, with high risk, I don't think you should ever do SBRT alone without hormones.
So this is all, so let me take this back a second, because I erroneously think that you would do hormones with in every case with a Gleason 7 or Gleason 9.
No.
That is not, because this is what I see, right? That's what's recommended over and over. I think your practice might be different, John, than others.
We bend over backwards to not do hormones. We use it probably a third of them.
Are you guys, is this standard or you different?
No, standard of care for Gleason 6 and Gleason 3+4 that have SBRT is to not do hormones.
Okay.
Patients that have a Gleason score 4+3, and I'd love to dig into this a little bit more because it's something I'm excited about that we just opened up at NYU Langone. Patients with a 4+3, many consider it a standard. So 7 can be a 3+4 or 4+2. We've had this discussion, right? So 3+4s and 6s, in my opinion, that have SBRT do not need hormones. They can have SBRT alone.
Gotcha. Yeah. Okay.
Maybe
it's the 7s, 4+3s that I've seen a lot of.
4+3s, the standard is to do some form of hormonal therapy or ADT, androgen deprivation therapy. It's not clear that that's indicated for every 4+3, and we now integrate genomics into our planning. The Cypher score, where it looks at the RNA of the cancer.
Hold that thought, because I want to dive really deep into that, just for clarity purposes. Higher than a 3+4 or 4+3 and up. Gleason 8, which is just a 4+4, Gleason 9. Gleason 8 and 9. Standard therapy, SBRT with ADT?
No, standard therapy for 8 and 9 is usually pelvic. If you're going to have radiation, encompassing the pelvic lymph nodes, giving the prostate a higher dose, and integrating ADT. Most people would not do SBRT and hormones for Gleason 8 and 9s.
Okay, so now off-label, hasn't been studied because we don't know, but Dr. Haas, I love you. 2 treatments, ADT. I'm willing to take a chance. Do you have those patients, or you just say no? You're not a candidate.
No, that's not. You don't want to deviate from the standard of care. And if you're going to if you're going to do something that's not yet a standard of care, you want to do that on a protocol, because you've already vetted the question to make sure that it's a safe question to ask.
Okay, and the reason for that is because the assumption is, and it's an assumption, that there's micrometastasis in some lymph node.
Pretty much, exactly right.
Even though all the imaging, including PSMA, which is the king and queen of imaging at this point. Yeah, got it.
So you don't want to undertreat. You don't want to overtreat. You don't want to undertreat. You want to properly treat. So most people, would not do SBRT alone. Certainly, most people should never do SBRT, in my opinion, without hormones for high risk. You can do SBRT and ADT for very limited things that NCCN guidelines indicated for, like we just talked about, medical or social hardship, and it gives us wiggle room. But no, you should make sure you encompass the lymph nodes. The 4+3s are interesting. That's where some of our newer research is digging into right now. So we just opened up a protocol at NYU Langone, led by Michael Zalewski, who I love, who you know.
He's with us.
Yes, he is.
He's with the dream team now.
Can you imagine, all of a sudden?
No, I can't.
Dr. Haas, would you like to have LeBron James on your team?
Right. And why was LeBron? And so then LeBron James left the Lakers to play with, I don't know, the Utah Jazz. Not that, NY we highly regarded, but, in comparisons to Sloan, we have great relationships with their institution as well. So this is not a beef situation. But to have him, first of all, as a Knick, what, John, I know you like basketball. What's your team? You better say the right thing,
I'm a Knicks fan.
Okay, thank God.
We
All
right.
right. We're cool.
Last Saturday's game, the last game of the season. This is my first time in the Garden all year. It was off the charts.
Just like the 90s.
Yeah, exactly right.
Right? Just like the 90s.
Yeah, it was like a Ewing game. When the Garden is humming, and the Garden was as loud as I've ever heard it since, John Starks, John Starks, by the way, he's interesting. I don't know if you should have him as a guest. He's a prostate cancer survivor, and I didn't
know that, but I met him once.
I can say that because he was a speaker at our course, so it's we're not breaking any HIPAA. He actually was at our men's health seminar, which you've spoken in the past. He was our speaker last year, and he gave a really articulate talk on his journey for prostate cancer. But the Garden last Saturday, off the
humming.
It was shaking. Overtime to get the number 2 seed. But so now I've got LeBron James on my team.
That's right, Zalewski. So go ahead and discuss. Let's get back on track. This is. I love that. Again, I love you. I loved you before. Love you even more now, man. Knicks fan.
Big love.
Let's do it.
So in any event, we opened up a protocol. Just opened up on Thursday or Wednesday of this week, and we're taking men with Gleason score 4+3, the unfavorable intermediate risk prostate cancer patients, and we're actually substratifying even by decipher by their genomics. And patients are randomized. It's coin flip. Half the patients get 6 months of ADT, half the patients don't. And we're substratifying it by genomics to see, because we think that there is a subset of patients that can have SBRT alone with no hormones. But we want to prove it safely through an IRB study.
And what genomics are you using to determine
using Decipher. That's the one that for this. I like Decipher a little bit better than the Oncotype. I'm not criticizing the other. I like it because I'm not that smart. You only have to know 2 numbers, 0.45 and 0.6. It just breaks up as an easy bar graph. Below 0.5, you're low risk. Above 0.6, you're high risk, and in between, you're intermediate risk.
It's nice and easy.
Really for those of us with limited intelligence. It's my knuckles barely come off the ground. It's a really easy test. But on a serious note, it looks at the RNA. It's a 22 RNA assay, and it breaks down the genetic predisposition if you have a more aggressive cancer. So we're trying to tease out. Men hate hormones, right? If your testosterone is going to be 0 for 6 months, that's awful. But if it's to your benefit health-wise, men are appropriately willing to do that. But if we can say, hey, there's a subgroup of patients, and if I was going to predict, I would predict it's the patients with the low-risk Decipher that are yet Gleason 4+3, that the hormones, you may not need it. So if I can spare you 6 months of 0 testosterone and not compromise your outcome, that's a home run. So that's what we're trying to do on this study.
I love it.
Yeah, I love it too.
How does arterial AI, right? So we have this technology that really radiation oncologists at this moment in time, the NCC guidelines approved for primarily radiation oncologists or to help the patient make the decision whether or not to include hormones or not. So by the time this episode is probably the conversation with Dan Spratt, which we go into arterial AI deeply, is already up. However, what are you guys? It's still very new. So what are you guys doing with arterial AI? Are you utilizing it in this study? Are you not, or are you utilizing it clinically?
So AI is not experimental. So we integrated a system about 3 weeks ago. This is our 4th week, called Ray Station. And Ray Station.
It's called what, John?
Ray Station. RAY Station. Ray Station. And it's an artificial or an augmented intelligence way for us to kind of do better planning for our patients.
Okay.
And so the way that we do radiation historically, so we talked about, we do what's called a simulation. We simulate the patient. In our hands here for prostate, we get a CAT scan and an MRI scan, and then we do what's called contouring. It's kind of like our OR. We're drawing the prostate, we're drawing the bladder, we're drawing the rectum. So now Ray Station uses augmented or artificial intelligence that before we don't even have to draw it right out of the gate. It automatically just appears. The computer says, this is the prostate, this is the bladder, this is the rectum, this is this. We modify it. the radiation oncologist now. So I'm using the AI is kind of teeing it up for me. And then I'm saying, okay, I want to kind of tailor it more. The Gleason, the Gleason 8 is on this side. Yes, this is the pure prostate, but I may worry about a little bit of extra caps or some microscopic extensions. I'm going to push out the border a little bit. I'm going to pull in a little bit here. And now we're able to come up with faster planning. So after I do my contouring, it goes to my physics staff. And historically, it would take them hours, sometimes days or hours to generate the radiation plan. Now with augmented artificial intelligence with the Ray Station, we can come up with a plan, probably half hour quicker. But we can now generate multiple plans, right? So we can say, well, this plan, here's plan one, but the AI said, look at this plan. And you can kind of weigh the pros and cons of different plans, and it's beautiful. And my head is exploding.
Wow. And still under investigation.
No, it's still it's standard. There's nothing experimental about Ray Station. It's an FDA approved product. It's just making us better. So this is not experimental. This is actually.
So this is because I'm having a hard time keeping up with what's happening with AI. I think the rest of the world is as well.
This is prime time now. This is
this is different than Arturo AI. Similar, same.
No, this is. I'm not going to get into the other because I'm not as familiar with it. But Ray Station AI, radiation planning AI, is here.
Okay.
In the clinic.
Great. And have they included it in the NCCN guidelines?
No, because it doesn't impact on guidelines, because once you generate the plan, with AI and human integration, you're still making sure the doses or the treatment was within the NCCN guidelines.
Great. So now what we have is the following. I'm summarizing. It feels like wow, this is so much has changed since we last spoke. Under investigation, 2 treatments versus 5. Amazing. So potentially, and I think it's going to be favorable, but that's just my hunch.
Yep.
That 2 treatments eventually it'll be standard of care. 2 treatments versus 5.
Yep.
In a Gleason score that's 4+3 or higher, the Decipher score will tell you, hey, this guy needs ADT, this guy can do without.
But still being done on a study to omit the ADT.
Sure. Well, I'm sorry, repeat that?
Still being done in our hands on a study.
Currently, yeah. I'm just thinking ahead. I'm just thinking a little bit optimistic. I'm a human. I am being a little bit emotional now in a positive way. So potentially 2 treatments versus 5.
Yep.
2 treatments, no ADT if your Decipher is, after below a certain number. Above a certain number, you need ADT. And now with Ray Station AI, then you can even do a better job targeting. And
we can do better. We think we'll do a better job targeting. We think we'll be way more efficient, to be able to generate multiple plans to kind of pick what we think is the best. We're able to kind of, let's say a patient, for whatever reason, let's say they're treated in an outpatient office, and they have something medical that requires them to go into our hospital office. We can now, rather than take hours and hours to replan the patient, we can push the button and say, okay, this patient is going from the CyberKnife at 264 Old Country Road, now is in the CyberKnife in the basement of the hospital. And because there's subtle differences between the machines, rather than have to do a full-on 2-day replan, we can do it in minutes and not delay the patient to get treated.
I'm hoping this, and again, this is, prostate cancer treatment is prostate cancer treatment. It's not no treatment is a walk in the park. And we're almost at risk of making it sound like, oh, this is some alternative treatment where you'll get a lot of benefit and no side effects. What are the side effects? It used to be, I saw a patient recently, and I haven't seen this in a while. I mean, most patients that do any kind of SBRT do very well. He had hematuria, right? So he had a lot of blood, and his Center for Hyperbaric Oxygen Therapy and so forth, right? What's the prevalence of these type of side effects? What are the other side effects that patients need to be concerned about?
Any doctor that tells you that there's 0 side effects is lying to you, right? Because no treatment has 0 side effects. They're lying. Mm-hmm. So again, getting back to the model, right? And I take this model to all of my patients. I've got them in all my offices. Prostate, bladder, urethra, rectum, where my finger is. So I always quote patients that there is a 2% risk of bladder bleeding. The reason for that, if you look at the bottom of the bladder, it indents into the prostate, right? So if you ever see a fisherman out in the sun, they get the blotches on their nose. They're called telangiectasias. They're abnormal blood vessels from the solar radiation. So similarly, you can get those same telangiectasias from the radiation given with any form of radiation. And sometimes they can bleed. So you can't get that number to 0 because that's just the anatomy, right? So to your patient, I quote my patients a 2% risk of developing hematuria or bladder bleeding. I quote them a 5% risk of developing rectal bleeding. Same reason, because the rectum is flush up against the prostate. Although we do have procedures now, we do a gel that now moves the rectum away from the blood to the prostate to lower the dose. It still gets some dose, you can have some rectal bleeding, but that's been shown to decrease the rectal bleeding and rectal side effects. You have a 2%.
Is that called a spacer?
Yeah, spacer. There's 2 or 3 companies that do it. They all kind of accomplish the same thing. Just creates space. It moves it out of the way.
Do you do this all the time, John, or not?
Most of the time. There's some contraindications if a patient has extracapsular disease on the outside of the capsule. Most people won't put the spacer in because theoretically you can put the spacer between the capsule disease on the prostate and the prostate and push it to the wrong side of the spacer. So if you have extracapsular disease, that's considered a relative contraindication to not do the spacer. There's a 2% risk of developing a stricture, means that the urethra can narrow. So if you see I do these 2 black lines here, they're just doing the urologist will do a roto-rooter to open that up. So there's a 2% risk of developing a stricture. So those are the major side of it. And the important one that we talk about, I quote a 25% risk of erectile dysfunction with SBRT and the CyberKnife. With the broader radiation, it's more like 40%.
Why is that? Are you hitting the nerves?
Some of the nerves, some of the blood vessels, and also our patients are not 20-year-old studs, right? They're, as men get into their 50s, 60s, 70s, they lose potency anyway.
What's your risk, even if it hasn't been studied, maybe it has, if a patient is, 10 out of 10 in the bedroom before SBRT, what's the percentage you would say?
I give them a 25% risk at 5 years of having erectile dysfunction, inability to have penetration. But you don't know that they might have had that anyway, right? Let's say you're 10 out of 10 at age 68, and then all of a sudden you're 71, 72, you lose a little bit off your fastball anyway, right? Yeah, so.
Okay, so you're saying within time maybe, so they get it at 68, get SBRT at 68, they're 10 out of 10, but maybe at 71, they're not, they're 5 out of 10.
Yeah, right. But there's medicines to help with that. There's Cialis,
but that would happen, that's probably,
if you look at 100 age-controlled men that did not have prostate cancer, a very significant percent of those patients are going to lose erectile function anyway, just because they're getting a little bit older.
Wow, this has been fascinating. I tell you, people say, well, Gio, you do, as a natural doctor shouldn't specialize in anything. I mean, we treat the person, not the disease, but I'm always learning, man. Things are evolving at rapid rates. And here, just when I thought I had it all down as it relates to SBRT, here we are. Final thoughts of where we are, what the patient should know that we have not covered, and where we're going as it relates to SBRT and prostate cancer.
So, SBRT is here. It's prime time, and I love it. Final thoughts: if you diagnose the prostate cancer, you're thinking of SBRT. Dig into the different centers that do it. Dig into, all things being equal, if you have access to an NCI designated cancer center, I think that's.
How would they know? Is there a list somewhere?
It should be on the banner of the place you're going to. Or alternatively, you can Google and see, there's a map of the different centers throughout the country. I mean, it's not the end of the world if you don't have one, right? Because there's great doctors that are not at NCI designated cancer centers, but all things being equal, the center's been vetted. Take home message, ask what studies are available. Am I eligible for them? And ask if you can speak to other patients. And make sure also that it's a multidisciplinary approach. Make sure that you have the option to speak to other subspecialties within men's health, that you're not being kind of forced into one treatment.
I love it. Thank you so much, John, for being on this Saturday morning. I appreciate you.
Thank you, Dr. Gio. Love spending time with you.
Thank you, everyone, for listening to this special episode. I'm sure this was useful to you, and you can make it actionable. There's a lot of points in here that they're actionable, inform you, and you can have better conversations with your physician or radiation oncologist. Again, thanks so much. Stay strong. Keep doing well. And I will see you next time. Much love. Dr. Gio signing off. Talk to you next time.
Thanks for tuning in to this week's episode of the Dr. Gio podcast. You can watch all episodes of this podcast and much more by subscribing to my YouTube channel If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgeo.com. I'll see you next time.